DMEK graft journey, donor to injector. Now we already have the basics of DMEK, right? Preparing the DMEK graft, it's not so difficult. It's just that you need the right tools and you should have your own technique. There have been various techniques published: Seema technique, pneumatic dissection, liquid bubble, and yogurt technique. But the conventional stripping technique still holds good and is the gold standard. Is the technique that I still follow. Published right from 2008. Then you had all the various other publications followed by that. A review of the evidence for in vivo corneal endothelial regeneration tells us that the corneal endothelial cell density is higher in the periphery. And in a DMEK graft, you want maximum endothelial cells. You want as much population of endothelial cells as possible inside your graft. What could you do then? Make your graft a little peripheral. Instead of making it right in the center, skew it little to the periphery. It helps you to take more endothelial cells inside your graft so that your DMEK dance, how much ever you dance inside the anterior chamber, you still have enough cells to hold the graft in good stead. Eccentric graft peel enhances cell density in graft, and possible peripheral putative stem cells are also there in the periphery, which will also help the graft to fare well. The graft preparation trolley is very important. These are the various instruments you require to have in your trolley. As Dr. Anita already highlighted, the two syringes I've shown here are BD syringes. They are the white piston syringes. They don't have the rubber cork. It's very important because they are looser to inject and aspirate. You don't want a very tight suction which suddenly gives way and you have to, grasp you suck the graft inside and damage it. My other go-to is the Gouda cannula. Because of the transparency, you can't see it well. The Gouda glass cannula, or probably even a Jones tube, would be my go-to for injection. A Petri dish with saline. Basically, apart from the injector, all the instruments are your regular OT instruments. There is nothing. Even the injector, like Dr. Anita said, you can have the do it yourself injector. The important thing is when you're having the Teflon block that you usually use, it has a hole in the center. The Teflon block that you use for PK, for punching, has a hole in the center. It is important to block that hole from the base so that the liquid doesn't flow out. In PK while punching, you don't need fluid, but in DMEK while punching, you want, when you're actually peeling the graft, you want fluid to be there. It should not escape through the hole. Then there are two kinds of, it's not going to the next slide. Excuse me. Yeah, so your tools, like I said, the BD syringe, there are two types of spears that I use. One is the PVA spear, the blue one, and the other is the cellulose sponge. The green cellulose sponge is a fast soaking sponge. The PVA spear is a slow soaking sponge. So when you have more fluid and just want to remove all the fluid quickly, you can use the green one. But the blue one you will use when you want the fluid to drain out very slowly in the presence of the graft in your field. This is the DIY injector sensor cartridge, the butterfly cartridge, which Dr. Anita already spoke about, along with the BD syringe. Okay, you need just a piece of IV tubing in between to make this. Now we come to the steps of graft preparation. First peel, staining, making a stromal window, marking the graft, second peel, and staining and loading your graft. These are the steps. So coming to the video of the first peel. So like she said, a 9.5 mm usually is the first refine that you use. The first refine size is determined by the graft, the donor. The second refine size is determined by the host corneal diameter. So remember, 9.5, once you have created a partial thickness, light tapping movements, this is the fast soaking spear. Then you create that 360-degree liftable. Now this is 360-degree. Here there is no hinge. All around you have to make a groove, and the peripheral DM has to be stripped out completely. No remnant or tag of the peripheral DM has to be there. Once you're sure that you have created a 360-degree liftable kind of groove, that could be done either with a Sinskey hook, it could be done with a femto hook spatula like she mentioned, it could be done even with a phaco chopper, a phaco chopper with a sharper edge. Once you have created that, only then attempt to lift your graft. Without doing that, if you try to attempt, you will be wasting your graft by creating unnecessary tears. So here I'm trying to lift my graft. This is a single one hand technique. My left hand is not having any forceps. Earlier it had a forceps, now it has nothing, only my right hand, and I'm peeling slowly. Look at the descent, that is the horizontal mark. Look at both sides, both ends. There should be no tear as you are slowly stripping. Once you have, here you have to retain a hinge. Here you don't peel completely. Once you have the hinge, you are punching the residual stroma. Now the DM is on one side. The DM is at the bottom. This side is where only the stroma is there, and you're punching with a 3 mm punch. You're drying. Now the graft, you're laying it back. So the punch is being made only in the stroma, not in the descendants membrane. You float it with saline, and without touching the graft, you can just absorb the fluid with your spear, and it lays down flat on its own. You don't have to touch the graft at all. So 1 point of touch is what you would like to maintain. Now, marking the graft, there are methods where you don't have to mark the graft, but take my word for it, in Indian eyes with dark iris, you do want to mark your graft. Especially our cases are dense stromal edema, you do definitely want to mark your graft. So you lift that window from the opposite side. Now you go to flip the graft, go to the epithelial side, lift that stromal window and dry both sides. Dry the endothelium descendants membrane and then put your F mark on it. Don't allow the F mark to smudge. Then you put the window on it and close it. Next you can flip your graft, bringing it back to the endothelial side. Now we go to the second peel. Here, like I told you, this will be determined. So if your donor is 11 mm, shortest diameter is 11 mm, then I would go for an 8 mm graft. So roughly about 3 mm downsizing. Again, light taps should do it. You want only a partial thickness definition. Stain with ribbon blue once again. Make sure you're seeing everything clearly. Now outside your 8 mm punch, you're peeling the rest. Now this 8 mm is your final graft. So you remove the descendants membrane outside it. Once you peeled outside the 8 mm, what is left is your DMEK graft. So you are going to hold that DMEK graft also only with one touch. Lift it and laid it back and stain it this time for 1 whole minute. With trypan blue for 1 whole minute. After staining for 1 minute, take the blue sponges now. The blue sponges are slow soaking and 2 blue sponges are important. If you take one, it will move over to one side. It will go and stick to the sponge. So you want to dry it from both sides. Once you're done with that, your graft is now ready to be loaded into the injector. Preparing the injector system, since I use a Guido cannula, this is the way you prepare the system. It's easier with a glass cannula because it has one broad end and one narrow end. The broad side is for loading, the narrow side is for injection. Make sure your entire tubing is free of any air bubbles, that is full of saline. And then you load your graft into it, connect the other end with a BD syringe and then disconnect the central tubing so that the whole system is in saline. So this is how you prepare your injector system. Now loading the graft, you put it in the petri dish which has saline, and with the broad end of the injector, just aspirate it. The BD syringe allows very controlled aspiration. There you have your perfect Goldilocks double scroll. Keep it submerged in the water, the saline, and then remove the other side. So check the F mark and orientation within the glass cannula before you inject. That will save you a lot of trouble of identifying the side once you have injected the graft. If your graft is looking like this, with so much of staining, it means the endothelial cells in those areas are not functioning. Please discard that graft. Don't use it for a DMEK. Issues with peeling, you may have a hard peel where you are struggling, like earlier was mentioned. If you are having difficulty and you are seeing so much of taut DM, you are going to face troubles. If you are sensing that there is one area which is tighter than the other, you want to skew your peel to the easier side. You don't want to keep pulling from the harder side. Now if you see, I sense that there is a problem on one side. Now I'm skewing the peel from the left side. I'm not peeling so much from the right and still maintaining the hinge. If you have a graft tear, again, you're pulling it from one side. If you sense a tear, go back and stain it and check if there is actually a tear. There is a radial tear. Convert it into a rexis, like it's called the Nike sign. You make it like a Nike. the trademark of Nike, and go to another area and complete your peel. Make sure you don't remove the hinge. Keep the hinge in place. Okay, so that's how you would manage a graft tear. Again, as far as marking is concerned, you don't want saline fluid there. So if there is a fold in the Descemet's membrane when you're marking, invert the graft, release the fold, stretch the DM back into place. You'll have to recap this graft, refloat the graft, stretch it nicely so that it's a very taut sheet. Then you can flip it back and mark it. But if you're doing second time, I would advise do it with a Sinskey hook so that you know exactly where your mark is going. Don't do it with the F because it blocks your view. So don't do it like that. Then you cap it back and you're done. Do not compromise on the mark though. Redo it if you have to, but do it. Second peel usually does not have any issues. Sometimes you may have the DM which is not completely torn in the second trephination. So if that is the case, you can use a 1R scissor to cut the second peel. That is the final graft. So once your graft is ready, you're all set to inject it. Injector tips, like I said, choose from IOL or different glass syringes. Check the graft orientation within the injector and use a plastic plunger, a white plunger like a BD system for aspirating and injecting. If you're having graft preparation failure, it's mostly because of extension of the peripheral tear into the central area. Don't allow it to extend to the center. Complete the excision without a hinge will cause a problem. Always maintain your hinge. And if you have tightly adhered tissue or brittle DM, identify it earlier and do the needful. Conclusion is stripping technique is highly recommended, especially with beginners. Cell wastage is minimal, so you don't have to depend on the eye bank. You can always strip your tissue on your own. Overall, endothelial cell loss is only 4 to 5% in the hands of the surgeon. It's simple instrumentation, and your dependency on eye bank for pre-stripped tissue can be minimized. But beginners should always have a backup tissue. So these are the various types of scrolls.